Hello, the title of my presentation is Early Extubation followed by non-invasive ventilation as an option. These are my potential conflicts of interest. And let me start from this pretty old slide we did several years ago, and which show you the possible use of non-invasive ventilation related to the severity of ARF. And at the top of the x-axis, you see we have the most severe forms of acute respiratory failure, and among this, there is a possibility to use NIV for weaning patients. So this is something we know from many, many years. And there is indeed a strong physiologic rationale for using NIV in patients who fail a spontaneous breathing trial. In fact, the pathophysiology of this failure include increased work of breathing, and NIV has been shown to reduce the work of breathing. Rapid shallow breathing, and NIV can improve this. Respiratory muscle weakness, and NIV unloads the respiratory muscle. Abnormal gas exchange, and NIV can improve it. Increase intrinsic PEEP, and NIV can counterbalance PPI. And finally, we can have lung recruitment and or atelectasis, and NIV can effectively recruit lung parenchyma. Now, there is also a strong clinical rationale for shortening the time of intubation, which is reduced need for sedation, which leads to reduced ICU length of stay and reduced rate of ventilator-associated pneumonia, which may decrease ICU mortality. We have three major studies. The first one by Stefano Nava, published in the Annals of Internal Medicine in 1998, so many years ago, where he shows that early extubation followed by immediate NIV application in COPD patients who failed a TPS trial was able to reduce the time spent on invasive mechanical ventilation. Data that were replicated by Giraud et al. In hypercapnic, not exclusively COPD patients, again in failure of one single TPS trial, and finally, later on by Ferrer and co-workers, who were able to apply this technique irrespective of the type of underlying disorder. However, 85% of patients included in that study that confirms the previous results are basically hypercapnic patients. Several other studies have been conducted on this topic, and there is a meta-analysis by Karen Burns published in 2014 showing that in the subset of patients with COPD, there is a net significant decrease in mortality when this technique is applied as opposed to standard weaning technique. However, when considering studies including a mixed population, the results were actually not so strong and not significant in favor of NIV. However, when considering the incidence of ventilator-associated pneumonia, irrespective of the underlying disorder, there was a significant improvement when the patient was early extubated and ventilated with NIV in replacement of the endotracheal tube. The recent guidelines produced by ERS and ATS about NIV in acute respiratory failure suggest the use of NIV to facilitate weaning from mechanical ventilation in hypercapnic patients, while they make no recommendation for hypoxemic patients. Indeed, in 2013, Susanna Ornico and co-worker found in a mixed population, this is a very small study, but there is a signal that the rate of reintubation was not affected significantly by the presence or exclusion of COPD, suggesting a potential role also for non-hypercapnic patients. This is the tracing from an hypoxemic patient during invasive pressure support, and then after early extubation followed by non-invasive pressure support. From top to bottom, you see flow, volume, airway pressure, esophageal, gastric, and transdiaphragmatic pressure. And as you can see, NIV was able to maintain the diaphragm and respiratory muscle effort at about the same level, which suggests that NIV might be useful also for this patient. And this is the first small randomized control study, a pilot study, shown that early extubation in hypoxemic patients could effectively maintain gas exchange and breathing pattern unchanged as opposed to invasive pressure support. And at the same time, the study suggests a potential role in reducing the overall time of intubation. But that was a very small study, and until 2018 and the early 2019, we had no new data about this topic. In this year, two studies were published nearly at the same time. The first, published in JAMA by Perkins and co-worker, included the vast majority of non-hypercapnic patients, while the second was done by my group. It's a multi-center Italian-Chinese study, and the study enrolled only pure hypoxemic patients. And this is the study by Perkins and co-worker. They enroll overall 364 patients, and with a few exceptions, very, very small numbers of patients who were not pure hypoxemic, the vast majority had pneumonia, post-surgery respiratory failure, trauma, pancreatitis. They were substantially hypoxemic patients. And the main outcome of this study was the overall time spent on mechanical ventilation, which means invasive plus non-invasive ventilation. And as you can see, there was no significant difference, as shown in this Kaplan-Meier curve, regarding the proportion of patients remaining on mechanical ventilation. So no effect of NIV with respect of overall time spent on mechanical ventilation. And indeed, the authors concluded that early extubation did not shorten the time to liberation from any ventilation. Quite different, our study was powered to assess the difference in the time spent on invasive ventilation, and we found there was a significant reduction. We include only a purely hypoxemic patients, and these are the results. The patient receiving invasive mechanical ventilation over time were significantly fewer in the NIV group as opposed to controls that were patient weaned with standard technique with the tube in place. However, when representing the same data by Perkins et al., which means overall time spent on mechanical ventilation, invasive and non-invasive, we confirm no significant difference between the two groups. And interestingly, we found that the major effect was observed in the surgical patients as opposed to medical patients. Now, when we consider the time to liberation from any form of mechanical ventilation, there were no differences, 5.5 days versus 6 days, and actually our results were not significantly different from those presented by Perkins and co-worker. Now, when we look at the second part of the conclusion by in the study published in JAMA, the authors show that the non-invasive group required less invasive ventilation, 1 versus 4 days, which is actually the same type of results we observed in our study. So basically, it is important to define whether for you it's more important to reduce the time spent on invasive ventilation or the overall time spent on mechanical ventilation, including NIV. And whatever your preference is, you should remember that this is a technique for a small amount of patients. This is a study by Christophe Giraud and co-worker, and they enrolled, starting from 500 and more patients, only 9% of patients that were weaned by NIV. And although the vast majority of these patients were successful, they were only a small fraction of the overall number of patients includes 9%, which represented, however, 72% of all intubated patients for hypercapnic acute respiratory failure. So in the end, at the present time, we can imagine to propose that this is a useful technique for some hypercapnic patient and might have a role, but further studies are necessary, also for selected hypoxemic patients. I wish to thank you for your attention.